honor to moderate this session. The American poet Ogden Nash wrote something called "No Doctors Today, Thank You." And the first line of that is, "They tell me that euphoria is the feeling of feeling wonderful. Well, today I feel euphorian." Today we should all feel euphorian because we're trying to do something wonderful, which is to raise the bar in respiratory care, making millions of people's lives better. And in this initiative, Euphoria is joined by many organizations, those for the chest, the European Respiratory Society, GARD, GOLD, GINA. We're also joined by nasal organizations, European Rhinology Society, International Rhinology Society, and we're joined by patient organizations, EPHA, the Patient Advisory Board of Euphoria, and we have Sinus UK also present. So we're working together for this great initiative. I'd like to show you the agenda. It is absolutely packed, so I'm not going to read all the way through it. What I am going to do is start us off by asking Professor Vibeke Bakker from Denmark to talk to us about the vision and mission of Euphoria in the context of respiratory disease, including prevention. And Vibeke is a professor of pulmonology and then also in the Department of Otorhinolaryngology, Head and Neck Surgery and Audiology in the Rigshospitalet in Copenhagen, Denmark. Vibeke.
Thank you. Thank you for inviting me and involving me. I'm going to talk about the mission and the vision of Euphoria, and I have some conflict of interest, both as advisory board, studies, grants, whatever, and I'm very happy about it. Next, Euphoria is very important, and it is an international non-profit organization, and we are happy to have included the best specialists in both upper and lower airways. We are forming alliance with the stakeholders, both nationally and internationally, in organizations, institutions, and agencies. And Euphoria is having a common target with implementing optimal patient care for allergies, chronic respiratory diseases, and comorbidity. We are based in Europe, but not only. And we are an unboundless organization. And our aim is to worldwide make alliance to implement optimal patient care. That's very important, and this is including prevention. Chronic respiratory diseases in children, adolescents, and adults include asthma, with and without allergies, with and without eosinophilic cells. You will probably hear a lot of them in this talk today. And it's the blood's in the blood or in the lower airways. The chronic rhinosinusitis is also with or without polyps, but also with or without eosinophilic cells. And that as well is in the blood or the nasal polyps tissues. Allergic rhinitis is pollen allergy, house dust mites, pets, whatever. And you can have asthma alone, you can have chronic rhinosinusitis alone, and you can have allergic rhinitis alone, and you can have all three together. We can also have chronic pulmonary disease, COPD, and that in the future we'll see whether it's with or without eosinophilic cells. Euphoria is aimed to bring specialists together from both primary and secondary care, and we do also include both public and private care. We have, as something new, created a patient panel, which include and ensure participation from the healthcare users. Euphoria create opportunities for new innovation thinking and the development of optimal care strategies. We have developed pocket guides for primary and secondary caretakers. And we have done it within asthma, we have done it within chronic rhinosinusitis and allergy, and we have done both for children and adolescents and adults. We work with e-learning platforms, podcasts, face-to-face meetings, and masterclasses. And we have formed an advisory board for patients. EUFOREA stands for European Forum, Research, Education, and Advocacy. And we make an alliance between stakeholders, the healthcare professionals, and the patients in chronic respiratory diseases. We go for, our vision is the optimal patient care and prevention by education, research, and advocacy. And the mission is based on medical science core in Euphoria, and we offer a platform to introduce innovation in healthcare, leading to value based on healthcare. Thank you.
Erica, thank you very much. We're not taking questions after each session. We'll have questions right at the end. So let's move on now to Professor Guy Bruxelles, very well named for this setting, who is going to talk to us. He's president of the BERS, and he's going to talk to us about physicians' perspectives on the shortcomings of respiratory health.
Thank you very much. So it's my pleasure to contribute to this session on respiratory health. I'm indeed the president of the Belgian Respiratory Society, working closely together with the European Respiratory Society. Next slide. Here are my disclosures of interest. So I'm a member of GINA, the Global Initiative of Asthma. I've been the guideline director of the ERS, the European Respiratory Society, and currently the president of the Belgian Respiratory Society. Next. And this is the two key messages, and I will focus on asthma in the European Union as the physicians' perspectives on shortcomings of respiratory health. First of all, with respect to treatment, in the European Union, more than 10 million people with so-called mild asthma, which does not mean low risk, but they have infrequent symptoms, these people with mild asthma do not have access to the best treatment, which is the combination of an inhaled corticosteroid with formoterol used as needed if they have symptoms of shortness of breath. This is the anti-inflammatory reliever. And this despite the fact, and so because it has not been approved by the European Medicines Agency, by EMA, despite the fact there is vast evidence of efficacy and safety of ICS formoterol as needed in mild asthma. It has been approved in more than 50 countries worldwide, from Australia to Canada, from Brazil to the UK, Switzerland, more than 50 countries. And both the global guidelines, GINA, and European guidelines, the European Respiratory Society, they have put forward strong recommendations to use ICS formoterol as needed in mild asthma. And then with respect to research, in the European Union, there's a huge need for a European platform to perform international pragmatic trials to optimize treatment of asthma and other chronic respiratory diseases after market authorization. Because when a drug enters the market, this is not the end of research. There are so many research questions which have not been addressed during clinical drug development. So next. So here you see the airways in a healthy subject as opposed to an asthma patient. Asthma affects approximately 15% of children and 8% of adults. And in the World Health Organization European region, there are 43 million people with asthma. And in 2019, there were 17,000 asthma deaths. So asthma can kill, and this is important to prevent. These are young people, and it's preventable death. Next. And so I will focus on the one hand, mild asthma, so GINA steps 1 and 2, and on the other hand, severe asthma, GINA step 5. Next. So in mild asthma, the preferred treatment, as recommended by GINA, the Global Initiative for Asthma, is the use of inhaled corticosteroid and formoterol as needed if the patient has symptoms of shortness of breath. Next. Already 30 years, it's known that the short-acting beta-2 agonists, such as salbutamol, albuterol, Ventolin, is associated with an increased risk of asthma death because it does not have an impact on the airway inflammation, which is the central cause of asthma. Next. In contrast, the use of inhaled corticosteroids, they decrease significantly the asthma risk, the risk of asthma death and asthma exacerbations. The problem with inhaled corticosteroids as a maintenance treatment is the low adherence. So 75% of the patients are non-adherent to daily maintenance treatment with inhaled corticosteroids. Next, the combination of inhaled corticosteroids and a long-acting beta-2 agonist, the LABA, is an ideal treatment for the maintenance of asthma because you affect both inflammation with inhaled corticosteroid and you cause bronchodilation with the LABA, the long-acting beta-2 agonist. Next, if you use now a fast-acting LABA, such as formoterol, together with an inhaled corticosteroids as an anti-inflammatory reliever, you have also the opportunity to treat the underlying inflammation if the patient uses this as a reliever for symptom relief. And this next has been shown in 4 large randomized controlled trials. I only show the data from the Sigma-1 trial. In patients with mild asthma, if you use the beclomethasone or budesonide formoterol as needed, instead of the SABA as needed, without any maintenance treatment, you reduce the asthma attacks by 65%, by 2/3. So we could also reduce asthma deaths by 2/3. Next. And so since 2019, already 5 years, GINA, the Global Initiative for Asthma, recommends a fundamental change for asthma management in patients with mild asthma. So treatment of asthma with short-acting bronchodilators, such as SABA, alone is no longer recommended for adults and adolescents. Next. So then on the other side of the spectrum, you have the severe asthma. Patients who are in GINA step 5, they are already on high-dose SS-LABA, have many complaints and still suffer from asthma attacks. Next. And there we have now 6 different monoclonal antibodies which have been developed and are approved by the European Medicines Agency, but they have only been compared with placebo. Next. So they have been developed in strictly highly selected patient populations over the short term and compared with placebo. However, we as respiratory physicians, we see patients who are much more heterogeneous, and we don't know which drug is best for each unique individual patient. Next. And so for the optimal use of these biologics in severe asthma in clinical practice, there are many research questions who are unaddressed. Which drug is the best for each unique individual patient? There are no head-to-head comparisons. Which biomarkers can predict the therapeutic response? How long do we need to treat these patients? So all these questions need to be addressed next. And there we need an international treatment optimization platform. It exists already for cancer. There's the Cancer Medicines Forum within Europe. But we need this also for other non-communicable diseases, including asthma and chronic respiratory diseases, where we put the patient centrally and we have that pan-European treatment optimization platform, and then in collaboration with the European Medicines Agency, with the health and technology assessment bodies, with the academia, industry, and the Biomed Alliance, we can then put together randomized trials in a pragmatic manner, pragmatic trials, where you compare different active treatments to choose the optimal treatment for your unique individual patient. And thank you for your attention. This is again the key messages for the treatment. If you can go back one slide, I will repeat. In the EU, more than 10 million people with mild asthma do not have access to the best treatment for ICS formoterol as needed. And in research, we need a European platform to perform international pragmatic trials to optimally use the drugs in unique individual patients. Thank you for your attention.
Thank you very much, Guy. Those are 2 hugely important points. Let's look now at the patient's perspective. And it's my pleasure to introduce Thijs Teeling, who is a member of the Euphoria Patient Advisory Board, to tell us about patients' perspectives on the shortcomings of respiratory health, including physical and mental health and the impact on daily lives. Thijs.
Thank you very much, Glenis.
Thijs, sorry.
This title was not invented by me, so this was a gift of Peter Hellings. And then you start to think about how can I approach this. And I realized that as a patient, I only know my own perspective. So I have discussed my ideas with the Dutch patient organization, the Longfonds, and together we try to assemble ideas of many patients, and that's the result of this presentation. For a patient, the most important thing is breathing. Air, I need air. That's why this picture is over there. And patients, they really face a lot of numerous challenges. And so also from the perspective of the patient as well as the practitioner, prevention of asthma symptom is a very important thing. However, patients also emphasize the importance of the symptom relief and overall mental well-being in managing their conditions. Being afraid of having no air, having no breath, it can really paralyze you. It also can have an impact, what I call social isolation, and being perspective and being seen as a negative point as they think you're a whiner, especially if you're in areas where there's a lot of people smoking and you're getting no breath, and they said, oh, okay, he's complaining again. In that respect, smokers are not the most social people those days. Patients also have more than one issue. They have comorbid asthma. For instance, there's 3 pocket guides. They're all applied to me. And that's in that case, you have to need to see different physicians, sometimes in different hospitals, and that can be a coordination problem. There is an approach of what we call multidisciplinary teams, MDT, and it's proven that if you approach the patient via an MDT, you really can have an improved outcome of the diseases, especially in severe asthma. Also, I think the patient is very important in communication to the doctor. Although I myself, as not an uneducated person, very often when I returned from the hospital, I thought, gee, I should have said this, I should have thought. You forget things. And I think it's very important that we coach patients that be prepared. There is, in Holland, there is an organization that call it Ask 3 Questions. What are my options? What are the possible benefits and risks of these options? And is this the best option for me? And in the end, what does it mean in my situation? Is there an alternative? How can I do it? I think it's very important that people are prepared to do that. And I think even doctors should promote their patients to make a written preparation for the visit to the doctor. Also, I think patient participation is very important. You're not alone. You have the organizations like Longfonds, you have the ELF, you have the EPHA. Well, I mentioned a couple of them, but I think it's very important that patients are aware of these organizations and are in contact or in permanent contact with these organizations to exchange ideas, to exchange also their experiences. And not only about complaining, but also knowing other better ways to do it. Also, the communication is from the patient to the doctor, but also from the doctor to the patient. And I think one important thing is the holistic approach by the clinician. Very often clinicians see the disease. This is the person with the impossible polyps, which I can never repair. Or this is the patient who is always coughing. But there is more behind it. Pay attention to what I call the wider benefit of positive health. People are more than their illness or their condition. It's also the background and also the caregivers around the patient. It's very important. And that's where positive health is on promoting. The emphasis is not only on the illness, but also on the people themselves. It is a person-centered, psychology-informed approach, and it's essential for the clinicians treating patients with advanced respiratory conditions. In the positive health, there is a way of presenting that. There is a number of about 20 questions that you can fill in, and then you can find out what are your bodily functions? Are you feeling healthy? And how are you feeling fit? How is your mental well-being? Do you feel happy? Is there meaningfulness? Do you have faith in your own future? Or look you negative at the future? It's very important for you, your illness and getting better. It's a quality of life. It's a standard expression, but quality of life is really a thing. Is it important to enjoy life? Is the glass half full or is the glass half empty? And then participation, like I said, having good contact with other people is very important, because otherwise you're getting isolated, you feel sorrow, and you feel yourself a loser. And then, of course, your daily functioning, especially if you're still in the working environment, it's very good if you can just work as a normal patient. So these 6 dimensions of health, individuals and healthcare providers can adopt a more holistic approach to well-being, and that goes beyond merely addressing general physical symptoms or alignments. Also, we are here in the European Parliament. They can do important things, because air quality is a very important thing for asthma patients. I think we underestimate the impact of air pollution. At the moment, it's the single largest environmental health risk in the European Union, and it causes significant damage to the ecosystems. And member states would have to establish a quality plan ahead of 2030, but it still has to be agreed, as far as I know. And this should be an important step to better protect our health and move forward in the path to zero pollution in our environment by 2050. Summary: coaching for patients, very important. Positive health training for clinicians, and move forward on the path to zero pollution. Those are the things together. Thank you very much.
Thijs, thank you for that important lesson, especially about pollution. It's now my turn to talk to you, and I'm going to talk to you about raising the bar in respiratory care, nasal disease in childhood. And my qualifications for doing this is I've run a pediatric clinic, a multidisciplinary one, since 1987. Actually, I'm no longer doing it, but I have done it for years. The bad news is that nasal disease is universal. A child has between 6 and 8 colds a year, and that's a Gaussian distribution. Some of them will be having a dozen. So children have snotty noses for a lot of the time. Allergic rhinitis is also common, and it's up to a quarter of the population in some countries. And we know that allergic rhinitis reduces quality of life, it affects sleep, and it reduces learning ability. And we also know that allergic rhinitis can progress to asthma. There are various different allergic marches. Some start with atopic dermatitis, asthma, then allergic rhinitis. But another well-recognized one is allergic rhinitis progressing to asthma. And the bad news is that many people ignore allergic rhinitis. Oh, it's just another cold. It's often mistreated. First-generation sedating antihistamines are given to children, or drugs untested on children are given to them. Or their sinuses get operated on by surgeons who really do not need to do that. So what's the good news? Well, the good news is that we are producing guides, and this is our guide for pediatric allergic rhinitis. And I hope, it's slightly small, but I hope you can see that the top line is for everybody. And it's very simple things, like reducing pollution, stopping parents smoking in the home, douching with nasal saline, identifying trigger factors, including allergens, and trying to avoid them where possible. And then we have various stages of treatment, And I'd like to direct your attention to the bottom part of the slide, where we have allergen immunotherapy. And that can be used as treatment for the more severely affected child. But also, you'll see an arrow coming in from the left. It can be used if you want to alter the course of disease. And that's important, because recently we have coined a term called pre-asthma. And our first paper has been published on allergic asthma. And one of the things signifies pre-asthma can be the presence of allergic rhinitis, particularly moderate to severe persistent rhinitis with house dust mite sensitization. And there is now evidence in the literature that allergen immunotherapy in allergic rhinitis reduces progression to asthma. There's also evidence for the monoclonal antibody dupilumab given to children with severe atopic dermatitis in a meta-analysis that there was less asthma in those children 2 years later on. That needs confirmation, but that is an important observation. So it may be that we can start to think about asthma prevention. This is the evidence for allergic immunotherapy in allergic rhinitis preventing asthma. And that, of course, means that we need to recognize allergic rhinitis and send it to the right people for treatment. Next slide, please. It also means that we need to do this reasonably early on in life, because this study, looking at the benefits of sublingual immunotherapy tablet in children, suggests that if you start it at age 5, you have a much better chance of reducing progression to asthma than if you start it at age 7 or if you start it at age 12. So we need to be using sublingual immunotherapy in children much earlier than we tend to do. Next slide, please. What are the needs? Well, we need to distribute our guidelines widely, not just have them on a website, but we need all of you to go out and proselytize, point out that these guidelines exist and are useful. We need to adapt them for patient education, and Peter has devised an ADAPT program, which we're going to be doing. And we want to increase the use of AIT earlier in childhood allergic rhinitis. Thank you. It's my pleasure now to introduce Professor Alberto Papi from Italy, and he works in the Respiratory Medicine and Research Center on asthma and COPD in the University Hospital in Ferrara, Italy, and he's a member of the Scientific Committee of the Global Initiative for Chronic Obstructive Lung Disease, known by the acronym GOLD. And Alberto is going to be talking to us about an action plan to arrest the epidemics of chronic respiratory diseases. Thank you.
Thank you. Thank you to Euphoria for the invitation. Thank you for the hosting member of the Parliament for inviting me. Yeah, I would slightly amend the title. It's plans, it's plural, because there is more than one action that we can take. It's multifactorial. And also arrest, I would mitigate into reduce, reduce the progression, because realistically it's what we can do at the moment. It is an epidemic. This is the last global burden of disease. And among the blue one, the non-communicable diseases, COPD, asthma, interstitial lung disease are certainly having a great proportion of it. And if we consider on the top that lung cancers share the same risk factor as COPD, the issue at stake in terms of prevention is really huge for respiratory condition. The next one we'll see specifically for the respiratory chronic condition, what has happened in the last 20 years. There is a huge increase in the overall number of patients affected by chronic respiratory disease, 40% in the last 20 years. Particularly in those countries, you can see the hotter one at high income, both in male and female, an increase in the number of deaths related to chronic respiratory disease, substantial 18%. Of course, the profile of the chronic respiratory disease varies with age. As it has been said, in the younger ages, particularly asthma, which is by far the most important one. Then we have the elderly, where asthma and COPD are there, altogether similar degree. What is important in this study conducted in England is that they tend to be comorbid to other conditions. We'll get back to comorbidity. And this comorbid state increase with age. So the frailty and the burden of the disease is greater with age, and with the deprivation index, the disadvantaged one have a higher risk. So we have to take care of this and to consider this. As an example, I would consider COPD for a change. COPD is a condition that is considered mainly related to exposure to tobacco smoking and environmental exposure. The symptoms are related to damage in the airways, airway obstruction. It can be easily measured by spirometry. The tool is easily available everywhere. I'm saying this because these are actions that should be taken, and we are not there yet. First of all, the Lancet Commission made this approach in elimination of COPD, and the first step has been to clarify that is not only tobacco smoking, it's exposure to environmental indoor pollution, it is early life events, it is infections, also to take out the stigma of a self-inflicted condition. Then the action type A are those related to healthcare, health professionals that are involved in policy making, actually. So the first statement of the Lancet Commission I'm quoting is that elimination is related to eliminating the risk factor. The potential of primary prevention is immense and incomparable to what we can do with treatment. So there is no other way that letting us breathe clean air and reducing the other risk associated, taking care of early life events of maternity. And the second action is that, well, in COPD, it's more than 20 years that we are stuck on the same drugs. We are modifying the combination, we are changing some, but we are still there, so we need a lot of investment that is deserved because of the importance of the issue for research and implementation of tools and drugs available. We are not there. If we look at what has happened in the last 20 years, there has been an increase both in pollution and in exposure to small particle, and tobacco is the most prevalent condition in westernized country. Even more worrying is the fact that the exposure to tobacco smoking is increasing among adolescents and among young women. So we have to expect an increase in these epidemics. So if this is the scenario, what's the action? First, measure it. We have a simple measurement that it is spirometry available everywhere. It's not used. This is data from the US health survey that says that, well, it's not diagnosed in 70% of patients with obstructive lung disease. It has not changed in the last 20 years, still 70%. A simple tool has been developed to help GPs, for example, the family physician, to identify patients that are cases, just 3 words, and we have to take advantage from what comes from the CT scanning patient at risk of lung cancer. As I said, the risk factors are the same in COPD, where abnormalities are found. Spirometry should be done. I'm pressing on spirometry and I'll get back at the end. Next is the clear recognition, it has been already mentioned that rarely these conditions are single condition in these patients. They are part of a concomitant multimorbid syndromic condition along with cardiovascular metabolic diseases, which means that if I identify one of them, I have to proactively look for the other, because I will be in the position to identify them earlier and to treat the complex of these diseases altogether and being able to approach in an earlier state. The frequency of having them together is higher when one is present, is more likely to have the other. These require a multidisciplinary approach, not in silos with different disciplines, but working together in a close relation, not only specialists, but also other healthcare professionals are required, physiotherapists, speech psychologists. And we are struggling with this. We are struggling because the resources are what they are, and the possibility of having an organized structure in a multidisciplinary team is still at this very basis. The other issue that goes along with it is moving from an hospital center characterization, which is for intensive care, intensive healthcare delivery, to a more capillary approach to the community. And the new technology can help. Telemedicine can be useful, from education to teleconsultation up to visits and rehab. I have to say that in this elderly patient, it's not that simple moving to tele anything, especially if they are alone. So it needs to be simplified. The bureaucracy is huge. The technology needs to be simplified. Again, resources are needed. Finally, prevention. It can be very simple. It can be very useful to have an instrument to be able to get it earlier. And there is a simple instrument, which is spirometry, that can do it. A patient in early adulthood with low spirometry are at higher risk of developing respiratory and non-respiratory condition. Actually, what happens is that they are more likely to develop a concomitant condition 10 years earlier. It's a sort of increased aging, starting with a low spirometric level and increased risk of mortality. So it's simple. This is a call for spirometry to be a vital sign, to be used everywhere and a different time in life, to have a measurement of the health status, the general health status, not only the respiratory one, like a canary in the mine, highlighting threats. So the problem, and this is my last slide, is that we need resources, human and technological resources, because we cannot do everything that has been done so far in the 30 minutes that we are allocated for a visit of a patient, if 30 is available. And then we need a huge investment in progressing, because in COPD we haven't had any new drug for more than 20 years. And this patient require more and more attention given the burden of the disease. Thank you for the attention.
Thank you very much indeed. Now we're going to have the action plan by GARD to improve respiratory health, presented to us by Professor Argu Yorganşoglu, who is working in Izmir, Turkey. Yes. And she is representing the Global Alliance Against Chronic Respiratory Diseases.
Thank you very much. It's my honor and happiness to be a part of this panel. So thank you very much for EUFOREA for inviting me to take part. My task today will be sharing with you the action plan by GARD. GARD is the Global Alliance Against Respiratory Diseases. Next, please. It's a global network convened by WHO, and it was launched in 2006 in response to a World Health Assembly resolution. And GARD's greatest achievement through the years was its ability to forge the collaborative partnership and to develop a shared vision with a large number of parties, like we are today, including professional medical societies, patient organizations, medical and pharmaceutical companies, NGOs, governments, and probably EU now, and WHO. So, but we had many successful things in the GARD countries, but the policies and the procedures governing in which the way WHO can work together with external partners have changed and have evolved in recent years. So it was the time for GARD to evolve too. And there are no other initiatives like GARD in WHO anymore. Instead, there are forums of NCDs like Global Diabetes Compact Forum. So GARD was the one to establish a respiratory forum within WHO. So we had a great history of 15 years and great group of experts and lots of experience in countries. Next, please. So what is the vision, goal, and objectives of this new form of respiratory? It is still GARD, and vision is same, a world where all people breathe freely. Goal is same, to reduce the global burden of chronic respiratory diseases. And the objectives are undertake the advocacy efforts, like we are doing today here, to raise awareness and thus build support for prevention, as Alberto has nicely showed us the data. Diagnosis after that, management after that. Prevention is so important. So we need to promote a networking. We need to promote for knowledge sharing a network. So we have members of the organizations, and I'm happy to say that we have currently 36 members. Next, please. And we have a steering committee. You can find here that the major actors in the respiratory community are in the steering committee, like first representing ERS, ATS, and CHEST, and other respiratory societies, GAP, a patient organization, GINA, GOLD, IPCRG, primary level is so important, APSR, Bangladesh, Turkey, and Tishrain, Kyrgyzstan network. This is the steering committee now. And CRDs are part of the global NCD agenda together. I'm happy to say that with the cardiovascular disease, cancer, diabetes, and mental health and respiratory now is a priority of WHO. So GARD is closely aligned with the WHO priorities in terms of WHO NCD Global Action Plan and the Sustainable Development Goals of UN. Next, please. So the WHO Global Action Plan was between 2013 and 2020, but now it is extended to 2030, aligned with the timeline of the SDGs of the Union. And this is the 2030 agenda for sustainable development. We need to reduce the premature mortality from NCDs, and we need to achieve universal health coverage. We value this a lot because we know that the access to medicine is not possible in some low and middle income countries. So we need to strengthen the implementation of the WHO Framework Convention on Tobacco Control in all countries in order to prevent these diseases. Next. So these are, GARD has identified 3 priority areas. One is improving access to effective care for people living with asthma and COPD in all parts of the world. It is global. We need to reduce the exposure of the key risk factors like tobacco, outdoor or indoor air pollution, climate change as well. And we need to expand and strengthen GARD networks through advocacy and networking. Next, please. And we have some good examples. Even now, we are planning to have a World Asthma Day in the 7th of May, together with GARD and Gina. And we are planning not to limit the message for just for one day. You know, the message of this year, Gina, World Asthma Day, is asthma education empowers. So asthma and education is all together. So we are trying to expand this message throughout the year for all the countries. And we are trying to do it on tobacco and on COPD. So we have communication platforms. We have a serious platform within the WHO corporate website to the formal matters relating to GARD. And you may find the terms of reference there and information how to join GARD, how to be a member. I don't have time to go into details. And you can see the list of the currently accepted members. And also we have another portal, WHO NCD Knowledge Action Portal. We value this portal very much. It is more flexible, more responsive than the series webpage. And it is aiming to enhance networking and sharing of resources. And also, not only communities, not all the institutions or societies, but the individual, to allow individuals to be a part of the GARD network. So how to join? I strongly and kindly invite you to go to the website for this link and to learn how to be a member. And from this page, you can also link to the GARD community on WHO NCD Knowledge Action Portal. Please contact us. Please welcome. You are more than welcome to join GARD. We will be stronger when we join forces, and I would like to finish with the motto of GARD. We are aiming a world where all people can breathe freely. Thank you very much.
Arzu, thank you very much indeed. It's great to think that we are a multidisciplinary team as well. Right, now the next speaker is Mrs. Susanna Palkonen from Finland. And she's going to be talking about the action plan by EPHA to raise the bar in respiratory health. Susanna.
Thank you very much, and thank you also to Euphoria for inviting, and I'm delighted to see another MEP talking about how important it's to be able to breathe. Next one. So, EPHA, we have the privilege and also the responsibility to represent patients with allergies, asthma, and COPD at the European level. We are 41 patient groups in 26 European countries, and our dream, our vision is Europe, where all of those millions of patients can have the best care that they can, and that safe environment, and this is very much related to breathing, and be part of all decisions affecting their health, whether it's about care or prevention. Respiratory care and prevention from patient perspective is really guiding everything that we are doing, and this year alone we have a report on standards of care for COPD coming up. We want to see what has happened since the last 10 years. Have things really changed for patients on COPD care? We also recently we launched a website about asthma, and it's based on the latest evidence arising from the global guidelines. And we realized that there is great inequalities happening on access to evidence-based information on your asthma for patients and families. And that's the basis of this website. And in the next World Asthma Day, there are translations coming about this website. We are also involved right here in Brussels on policies like the EU pharmaceutical legislation or the EU health technology assessment legislation. And our job is to bring respiratory and allergy patients' perspective into these policies. And that's why I am Finnish, but we are based here, right here in Brussels. Next one. So in 2019, we started to imagine a collaboration where European-level patient groups and doctors are together. We realized that we are all doing our own advocacy, and we don't even know what the other groups are doing. So today we are called the European Lung Health Group. We are the European Respiratory Society, the European Lung Foundation, EPHA, and all our fellow respiratory patient groups together, from the rare diseases into tuberculosis. And we are really have cemented our collaboration and have come up with the vision together for 2030. And this vision is the BREATHE vision. And it was recently launched, and we are working together on a roadmap, on a pathway to improve care and prevention for respiratory diseases. And this is why we have launched together this year a campaign. And this campaign is about breathing. The campaign hashtag is Keep Breathing. And this is what we want Europe to do. And it was mentioned by you, just that this is the most important thing that patients with respiratory diseases need to care about. It's the breathing. Next one. So here we have listed some EU initiatives or policies that are actually affecting lung health. And that is why in this campaign we want to take a cross-cutting approach to show our policymakers why we need to have a real vision also at the European level on lung health. Today, lung health policies, they are very, very fragmented, and that's why it's important that also respiratory diseases become a priority at the European level, alongside with other important diseases like cancer and also mental health, which is also important in respiratory diseases. Next. I have brought with me a policy briefing that we have done on European policies that are affecting lung health, and I invite you to take it. We launched the Keep Breathing campaign a couple of months ago in an online webinar together with the MEP colleagues of our host today. And it is really great to see that the European Parliament is ready to support lung health. And now we will have elections in June for the new next European Parliament. And this campaign will be also promoted to the new European Parliament. In fact, lung health is in fact something which is affecting cardiovascular health, it's affecting the immune system, and we all have lungs, and we all need to breathe. And as a community of respiratory disease patients and doctors, we are all going to have to bring this message because it's about all people's health, not only patient health. Yes, I already mentioned the event and on launching the campaign, and in fact, the MEPs, 3 MEPs hosting the event, they really made very strong statements on how they are going to work on lung health. And we also discussed in this event about recent budget cuts that we have seen on health at the European level, and that makes us worry a lot what is going to happen next. Can you move? So our policy is to keep breathing, and we are asking Europe that what is your policy? So let's all keep on breathing together, and we invite you all to join this campaign. Thank you very much.
That's a great initiative, and it reminds me of the yoga class that I do online, where every so often the instructor reminds you to remember to breathe.
Glenis, I was going to say in the beginning of the talk that this is not about yoga. So.
It's now my pleasure to introduce Professor Witske Fokkens from the Netherlands, who's going to talk to us about the action plan by the European and the International Rhinologic Society to raise the bar in respiratory health. And Witske is currently, I think, the Secretary General of the International Rhinologic Society,
yeah.
Recently elected.
Yeah, thank you. Thank you very much, Glenis. I would like to show you the vision and mission of the European Rhinologic Society. Of course, very important to realize that most patients with lower airway disease actually have upper airway disease, and that the upper airway disease usually does not kill people, but really makes their life very miserably, often more than the lower airways. So the European Rhinologic Society provides a forum for the exchange of experiences among specialists interested in rhinology, allergology, and the rest of the upper airways. And this goal is achieved by congresses in cooperation with the international, with the ASEAN, courses, fellowships, and awards. And the International Rhinologic Society is created to be a central international organization as an umbrella organization over all rhinologic societies regionally to organize congresses, instructional courses. We have a course next week in Turkey to help young colleagues from Ukraine and Eastern Turkey, that part of the world, to really go up to the international standards of treating our patients. Chronic upper airway diseases are extremely prevalent. The prevalence of asthma in adults is about 8%. Allergic rhinitis is around 25–30%. So that makes it a very debilitating and important disease, which has a great impact on a large part of the European population. And the same is true for chronic rhinosinusitis, where it's about 11%, resulting in a high burden of upper airway disease. The cost of rhinitis, for example, are between €0.5 and €1 billion per million inhabitants per year. And that's not direct cost. A nasal spray is not very expensive, but the indirect cost of people not going to the work or being at work but not presenting properly is extremely high. Imagine how you feel on the third day of a really severe cold. That's how those people feel every day of their life. And it's very important that they have access to proper treatment. For rhinosinusitis, it's the same. It's about €500 million per million inhabitants per year. If you compare that to the cost of asthma, it's much lower, and that has a lot to do with two things. One is the reduced prevalence. Of course, if there are less people having the disease, it's less of a problem. And the second is that the access to treatment, although bad, is still much better than that of the upper airways. So the European Rhinologic Society tries with stimulation of research, especially now with real-life trials. We have a lot of data on studies, but very little data on what happens in real life, how to get the best treatment to the best patient. And that needs a lot of education of physicians, but definitely also of patients to raise awareness of these diseases. Yesterday we had the Chronic Rhinosinusitis Awareness Day, and I was really impressed by a general practitioner who didn't recognize that she actually had chronic rhinosinusitis for years. As even physicians are not able to recognize that they have the disease, what will happen to the general public? So we need education of physicians and patients alike, and the stimulation of research in the field. There is organization of educational events, as I said already, live events, very important to meet people, but also lots of virtual events, either within the format of a European Rhinologic Society or very often combined with either the IRS or EUFOREA at the moment. We also have European guidelines. These are the European guidelines for chronic rhinosinusitis, and they're not only there for physicians, as you can see here in the middle, the last one was in 2020, but also there is one for patients. Very important to help patients to understand what they actually have, what they have to discuss with their physicians. The European position paper on rhinosinusitis not only talks about chronic disease, but also in the upper airway, extremely important, acute rhinosinusitis, very often misdiagnosed and treated with antibiotics. And I'm very proud that the EPOS, European Position Paper on Rhinosinusitis, induced a significant reduce of the overuse of antibiotics. The teaching we did all over the world to stop using antibiotics for acute rhinosinusitis has obviously resulted in a reduction, and there is a very interesting survey in Asia who showed that after the publication of EPOS, the amount of use of antibiotics has significantly reduced. We made a new classification of chronic rhinosinusitis to better endotype patients and to be sure that the best treatment is given to various patient groups. Proposed care pathways all through the society, from self-care, what does the patient have to do before they actually see a physician, to primary care and eventually tertiary and tertiary care. And of course, this is what we eventually want. We are now still trying to get patients controlled, have absence of symptoms, in the recent period. But of course, eventually, we want to achieve remission of disease and eventually cure. And extremely important is the relation with the lower airways. If patients' upper airways are treated better, eventually also their lower airways will be better. Thank you very much for your attention.
Thank you, Vitsa. That's an excellent effort being done by IRS, ERS. Wonderful. Now it's my very great pleasure to introduce Professor Peter Hellings. His action plan to join forces with all stakeholders for respiratory care.
It's a pleasure to be here, especially feeling very privileged and honored to be with such an exquisite panel of people representing wonderful organizations. So I cannot hide my excitement about the fact that we all feel there is the need to undertake action. We cannot stay passive. And without having pre-aligned with all the other speakers and organizations, I'm very happy to share that the first part of what I will share with you is actually fully aligned with what have been said by the patients, by the other organizations, and then I will also share the action plan of Euphoria for the next 10 years. So the time to act is now, and I just want to remind you first of the fact that in 2014, the former Commissioner of Health, Vytenis Andriukaitis, encouraged someone to make a new foundation that would bring patients and physicians together around respiratory diseases, joining forces between the upper and lower airway specialists, joining forces with politicians across boundaries, and not being paralyzed by any political, personal, or other obstacle, just trying to do what is needed to help patients and to implement optimal care. And that is exactly why Euphoria was founded, thanks to the support of the Bayela Tour Foundation in 2015. But the time to act is now, and I just would like to remind you of some perspectives that have been given by some of the faculty members here during this symposium, Raising the Bar in Respiratory Care. First of all, there is the societal perspective. You heard about the epidemics of chronic respiratory diseases, and just 2 weeks ago, we were in Tokyo hearing that already 50% of the Japanese population is affected by respiratory allergy. Here in Central Europe, it's 35%, but can you imagine that 1 out of 2 patients or 1 out of 2 citizens in a country are affected by pollen allergy? So we are still far from there, but it may increase if we do not undertake action, as also Professor Scadding mentioned. There is a lack of focus on prevention, and there is a lack of focus on optimal care. There is increasing cost of chronic respiratory diseases. You heard that as well by Professor Brussel and Professor Papi. And there is a lack of smart use of health data. And please remind that as well. We do have health data, but they're not used in a clever way. From a payer perspective, there is a lack of value-based healthcare because some of the new treatment options that we have are excellent, but are still costly, and we need to make sure we focus on bringing value to the patient without exceeding the current costs of care. Because we do know there is a high cost of delayed diagnosis and also suboptimal care, and as mentioned, the novel treatment options are costly. Next slide. So from a scientific perspective, you have heard also by the other lecturers here during this symposium on raising the bar in respiratory care, there is prevention within reach. We have allergen-specific immunotherapy for allergic rhinitis. We may have the biologics that we consider to have a disease-modifying potential. And we lack actually a uniform approach in implementing the algorithms of care. Euphoria developed simplified treatment algorithms for asthma, for chronic sinus disease, for respiratory allergies, but they need to be implemented and even applied more in common practice or in daily practice. And that is the way why we think we should act also. And there is a lack of user cases of artificial intelligence and big data in chronic respiratory diseases, and I think we all recognize that. And last but not least, the patient perspective is also the reason why we should undertake action, because there is a significant loss of quality of life, as you also heard by Professor Witzke-Fokkens. There is a lack of comprehensive care for chronic respiratory diseases because patients are being paralyzed because they see different healthcare providers who tell different stories, who are not consistent in the recommendation of the therapeutic plans. There is a lack of lifestyle advices being given, so there is a huge unmet need to provide comprehensive care for patients suffering from chronic respiratory diseases, limited empowerment of patients because patients do not find relevant educational material on websites, on social media, and also inequalities of care need to be addressed more. This topic was also proposed by Professor Guy Brussel, and we also know that despite the availability and all the scientific evidence we have for biologics being excellent treatment options for patients with CRSwNP, that still these biologics are not available in all European countries. So there is the need to undertake action, and I would just like to remind you of what Euphoria has been focusing on the last 10 years. So the R stands for research, the E for education, and the A for advocacy. And this is indeed the 7th time we come to a parliament to bring the story and highlight the need of action and how we can improve care, including prevention. Several of you have been involved in the educational activities of Euphoria, and the last 3 years we trained over 30,000 physicians on CME-accredited information and educational courses, which is, I think, a good achievement. There is research and real-world efficacy data research ongoing, as well as validation tool for defining control. And the advocacy events, well, that's the reason why we're here for. But if we think of the next 10 years, then we want to mainly show the impact of euphoria, not only in Europe, but also in the US. And therefore, we are now developing strategic partnerships in a new program that is called ADAPT. If I may have the next slide. So ADAPT stands for Airway Disease Action Plan for Preventive and Personalized Treatment. I think it's a nice acronym, and ADAPT is indeed the way forward for euphoria. And can I have the next slide, please? Because there we will first start with the development of a patient support platform that really provides support for patients through artificial intelligence-driven programs that are currently being developed and that are available. And we are now establishing the partnerships in order to make sure that the treatment algorithms that have been developed can always be and also be implemented in daily practice. And when we do so, we bring integrated care solutions to reality, and we also can focus on early diagnosis, optimal care, and value-based healthcare. So next slide. This is, for instance, the quality criteria that Euphoria has designed and published in the WOW journal 2 years ago, where we already defined the 16 criteria that should be met in order to have a high-quality e-health tool for chronic respiratory diseases, addressing the current needs and the current unmet needs in order to make sure we can progress. Next slide. And in the first phase, which will be developed quite soon and will be launched next year at the time we celebrate 10 years of Euphoria, is the patient educational portal that will finally allow patients to be empowered. Since 2015, we have been talking at advocacy event on the need for patient empowerment, but we do believe that patient education is the first tool that will allow patients to really get access to trustworthy information and be really empowered. In the second phase, after having developed a patient educational portal on chronic respiratory diseases, artificial intelligence-driven optimal care pathways will be offered to the patients as well as to physicians in order to make sure we shorten the disease journey, we increase or we optimize the treatment plan, and we try to make sure that the right patients do get access to the right therapeutic advices. And the third phase, which will be 27 and beyond, will all be about the demonstration of the impact of what Euphoria can realize with its partners. Of course, this ADAPT program can only be realized when we have the right partners on board. Next slide, please. And when we stick also to our core values, and all of you who know Euphoria understands and will agree that Euphoria stands for inclusivity, integrity, and that we will also move forward now with big data and artificial intelligence and also unique partnerships, because without unique partnerships, we are not capable of doing or making a meaningful change. Next slide, please. And our partners are, first of all, the biggest assets of Euphoria, which is not only the wonderful team that is behind the daily business of Euphoria, but also the expertise that is available from top experts from different specialties, and also not to forget the patients with whom we collaborate very closely. Next slide. And of course, all the partners with whom Euphoria works, academic partners and also partners from industry, they're very important for us in order to make sure we can realize the action plan that we now believe should be the next step. Next slide. So I do believe the future is bright, and I hope I can inspire you to join forces even more in the future with Euphoria, because in the end, there is time to act now. I think the future is bright, and I thank all of you for being here, and especially the management team of Euphoria, who has been very active in making all of this symposium possible. Next slide, please. And this is mainly Mrs. Elisabeth von Stein, Mrs. Tanya Lopez, and also Katie Tassel, who made all of this day and this symposium and raising the bar in respiratory care possible. So thank you very much for your attention.
Thank you, Peter.
Thank you so much. To me, the honor to close this session. To me, the honor to close this session. And thank you for attending this conference in the European Union. I think we've raised a couple of very important issues today. And I hope I will see you again next mandate, not because I will be elected, of course, but also because I think if you want to put this important issue on the agenda of respiratory diseases and the treatments, it's very important that you have a long breath, as we say in the Netherlands. So it takes an effort, and it takes a little bit of endurance. But if we communicate our goals and objectives clearly, and we are determined, I'm pretty sure that success will be there within the next term. So the things that you raised here today that you think are of the highest importance are not the most difficult ones to achieve. And I think it doesn't matter if you are left or right. They are just common sense and logic. And this is very important, I think, because this means that the opportunities to get a majority within the European Parliament are easy to make. So I'm hopeful that we will achieve something in the near future. Again, I would like to thank you for that you are here for your and I hope that you can see some of the Parliament. I heard that you get a sort of small tour now after we've taken a sort of group photo together. Thank you again, and I hope to see you soon. Thank you.